Hello everyone and welcome to my YouTube channel. In this video, we will discuss various clinical trials related to traumatic brain injury in this section of neurology, sedation and analgesia. It is quite big section, so I've divided into various subsections. And in this subsection, I'm going to talk about the trials related to traumatic brain injury management. The role of ICP intracranial hypertension on herniation and mortality in traumatic brain injury has been recognized since the time of papyrus, when this book was published, Edwin Smith Papyrus in ancient Egypt. Direct measurement of intracranial pressure was developed in 1950s and has since become standard of care in traumatic brain injury patients and other types of patients also, for example, SCH and ICH patients. Level of recommendation is usually low. The Brain Trauma Foundation recommends using ICP data to reduce the mortality, and this recommendation is just level 2B recommendation because of lack of stringent study, the robust data. However, standard continuous ICP monitoring methods are invasive most of the times, and treatment are often non-specific based on ICP monitoring, and they may have serious side effects, raising the questions about the necessity, the timing of ICP measurement in traumatic brain injury patients. In 2012, Chestnut et al. Conducted this trial, which is known as Best Trip trial, 10 to 12 years back. It involved 324 severe TBI patients randomized into SOP protocol. Group was treated based on intraparenchymal ICP monitoring group, that was pressure monitoring group, and other treated based on imaging, CT scan or clinical examination findings. So that was clinical imaging examination group. The primary outcome was composite of survival time, impaired consciousness and functional status along with neuropsychological status at 6 months. Definitely no significant differences in the primary outcome were found between the two groups. If you look at here, the composite outcome was 56 versus 53. It was a little higher in pressure monitoring group, but the p-value is just 0.49, show any difference of outcome. The trial indicated that ICP monitoring did not improve the primary outcome compared to management based solely on clinical and imaging findings. Despite this trial, intensivists were not discouraged around the world. They continue to utilize ICP monitoring for traumatic brain injury patients. Recently, about 4 years back, 2021, international prospective observational cohort study on traumatic brain injury was published in Lancet Neurology, which is a journal of repute. This study was conducted across 146 ICUs in 42 countries, taking about 5,000 acute brain injury patients. Among them, approximately 54% patients were traumatic brain injury patients, and rest were ICH and SAH patients. The study found additionally the median TIL. What is TIL? That is therapy intensity level. This is one outcome measure. So they found that TIL was higher in the monitored group compared to non-monitored group, but meaning that the patients where the ICP monitoring was used, they were exposed to higher intensity of treatment. Okay. However, this higher intensity of treatment was related to mortality benefit, and they showed that 6-month mortality was lower in patients with ICP monitoring, 34% versus 49% in the standard group without monitoring. So this study shows the value of ICP monitoring. Later, in JAMA, this is another study which was in contrast to the Synapse ICU study. It was published in 2023, which involved around 1,500 critically ill patients from 43 ICUs in Italy and Hungary, and they found that a patient with ICP monitoring had worse Glasgow Outcome Extended Scale, that is GOSC, at 6 months compared to matched non-monitor controls and received medical therapy significantly more often. So this study showed opposite. It shows that ICP monitoring favorable. It may be associated with more harm because the GOS scores at 6 months were worse with the ICP monitoring, probably related to more complications related to therapies which were directed at decreasing the ICP. This is study. Now, in 2024, there has been an umbrella review of 5 systematic reviews and meta-analysis encompassing 49 primary studies. It concluded that there is no mortality benefit from ICP monitoring in TBI patients. So in a nutshell, you can use ICP monitoring, but not if it is not available. There is no need. ICP elevations are often a late and insensitive indicator of secondary brain injury, as many research articles have noted. Many scientists have noted, and you should not depend on ICP. This has been already covered in the previous studies, except Synapse ICU. I think we have to wait for very good trial in TBI patients, but we have another monitor. One critical parameter is the brain tissue oxygenation, which is essential for cellular metabolism and viability of the tissues in the brain due to brain's continuous demand for oxygen and glucose. You know that the brain cannot tolerate lack of oxygen or lack of glucose. And observational studies indicate that brain tissue hypoxia can occur even with the normal intracranial pressure or normal cerebral perfusion pressure. May depend on the metabolism for the diffusion, on the diffusion defects rather than perfusion issues. So diffusion of nutrients and oxygen and glucose is also very, very important, and that can be monitored using brain tissue. A few studies on brain tissue oxygen monitoring, I think we can evaluate in the next slide. So remember, average PbtO2, that is brain tissue oxygen tension, is 23 plus minus 7 millimeter of mercury, and studies have shown that reduced PbtO2 brain hypoxia is common after traumatic brain injury, and if the value is less than 20 millimeter of mercury, that is associated with worse outcome. And they have found that in about 70% of TBI patients, they may have value less than 20 millimeter of mercury as per observational studies. So this was a trial called BOOST-2 trial, which is a phase 2 study, not phase 3, phase 2 clinical trial published in 2017 in the Journal of Critical Care Medicine, which is a reputed journal. It involved 119 patients, about 120 patients in USA ICUs, and they were randomized to treatment protocols based on ICP plus brain tissue oxygen monitoring versus ICP monitoring. There were no third control where no ICP monitoring was used. Actually, PbtO2 was evaluated against the ICP monitoring and found that 6 months Glasgow outcome scale was better, and there were less episodes of brain hypoxia. Okay, so this was the primary outcome in BOOST-2 trial, 6-month GOSC score, which was showing a trend toward lower mortality and better disability outcome in ICP PbtO2 group, although difference was not statistically significant due to small sample size. However, the Data Safety Monitoring Committee halted this trial because it showed primary outcome with a smaller size than initially planned. So it showed favorable outcome, and results suggested that PbtO2 directed therapy is not futile, and they gave green signal to perform a phase 3 study. So BOOST 3 is going on, and we need to wait for its publication. However, subsequently, there have been other trials conducted apart from Boost 3 trial, for example, OxyTC trial. So OxyTC trial was published in 2023 and recently in Lancet Neurology. Readers are encouraged to read this article, very good article, which involved 318 patients from 25 French hospitals. They were randomly assigned to ICP versus ICP plus PbtO2 monitoring group, and the primary outcome was same. The proportion of patients with GOS 1 to 4, that is favorable outcome, the worst outcome, death to severe disability. So this is the GOS score. As you can see, red is the death, patients with death, okay, and then blue and light blue. So these are all worse outcomes, okay, vegetative state, lower disability, etc. So it indicates that combining ICP and brain tissue oxygen monitoring did not reduce the proportion of patients with GOS scores of 1 to 4 compared to ICP monitoring. It was 51% in the PbtO2 ICP group compared to 52% in other groups. So there was not much of difference. And again, this is not a good study. It is not favoring the PbtO2 monitoring. So this is your OxyTC trial. Now we have to wait for Boost 3 trial results and Bonanza trials, which are still pending publication. Next subsection is decompressive craniectomy. It is also very important topic. It is important therapy, lowering the ICP. Okay, so it was first described by Danish-born British surgeon Anand Deal in 1894. So it is about more than 100 years old technique, and it showed managing refractory intracranial hypertension is feasible with decompressive craniectomy, okay, especially after traumatic brain injuries. It was shown by this man and later his peers and subsequent generations of scientists and researchers. So largest trial have been published recently in last 10 years, that is DECRA trial and Rescue ICP trial. So we are going to discuss the first trial, which was published in NEJM in 2011, DECRA trial, conducted over a decade in the centers across New Zealand, Saudi Arabia, and Australia. And the results were published in 2011 in this journal. It assessed the effectiveness of early decompressive craniectomy in patients with severe diffuse traumatic brain injury and refractory elevated intracranial hypertension. So they said refractory because stage 1 and stage 2 treatment were failed. So decompressive craniectomy was used as a last resort when ICP was more than 20 despite stage 1 and stage 2 anti-intracranial hypertension treatment. So this trial included 155 patients, and they showed that the mean reduction in ICP was significantly lower after decompressive craniectomy, as you can see in this figure. However, median GOSU score at 6 months was worse with the craniectomy patients. Okay, it was actually worse, as you can see in this figure also. And in this table, you can also observe the results of trial were somewhat unanticipated, showing DECRA. So DECRA trial showed that decompressive craniectomy was able to reduce. Was not able to reduce the mortality. If you look at the mortality, it was 18% versus 19%. There was not much of difference, and even disability outcomes were not good. Okay. So it showed rather DC cohort had worse long-term outcomes. So conclusion, DC was associated with more unfavorable outcomes as dictated by GOSU score. Therefore, in 2016, this trial was published on 408 patients, little larger trial. In this trial, ICP more than 25 was an indication for randomization into trial after stage 1 and stage 2 treatment was failed. Okay, the stage 3 treatment was subjected. Patients were randomized into surgical group and medical group, and primary outcome was GOS at 6 months. What they found was very encouraging. They indicated that similar rates of moderate disability and good recovery between both groups. However, the surgical group had higher rates of, disability despite the mortality reduction. If you look at this disability, it was higher compared to surgical group. Let me switch on my laser light. So this is your disability. Orange, light orange, yellow, this is your disability, which is higher in surgical group compared to medical group. But if you look at the mortality is lower in surgical group compared to medical group, as highlighted with dark blue color. Okay, navy blue color. Okay. The study concluded while the compressive craniectomy may reduce the mortality, but it was associated with a higher rate of severe disability. So, when you are talking to the patients with TBI, severe diffuse TBI, patients relative especially, and then giving the option of decompressive craniectomy, you can tell that the mortality may be lower, patient will live, but with the disability, and that will be the severe disability. But that has to be discussed with the families very, very carefully. The outcomes may not be good, the patient will be dependent. Now we are going to discuss the role of induced hypothermia. Induced hypothermia has been shown to reduce the ICP, to reduce the cerebral metabolism, the requirement of oxygen, and offer neuroprotective effects. Okay, it is also a treatment for the hypoxic brain damage, caused by the cardiac arrest, So we were expecting the same effect for patients with severe TBI. There have been two major trials conducted. You should remember, as far as TBI patients are concerned, Eurothumb and Polar trial. Eurothumb trial was published in NEJM in 2015. The Eurothumb trial involved 387 patients, about, you can say, quarter to 400 patients with primary closed traumatic brain injury. They were not open traumatic brain injury, they were closed traumatic brain injury, and ICP exceeding more than 20 millimeter of mercury for at least 5 minutes, and refractory to initial treatment. So these patients were randomized to two groups. One group was control group receiving the standard care. Another group was receiving hypothermia. The temperature was induced. The therapeutic hypothermia was induced, and temperature was kept between 32 to 35 degrees Celsius alongside standard care. So that was one arm, the hypothermia group. The primary outcome was GAUS score at 6 months, with lower scores indicating worse functional outcomes. So what they found, that the outcome was worse with the hypothermia group. Okay, so adjusted common odds ratio for GAUS score was 1.53, indicating a worse outcome in hypothermia group compared to control group. So in nutshell, Eurothumb 32 to 35 trial showed worse outcome with hypothermia. Hypothermia should not be used for patients with severe TBI, closed TBI. Then there is a second trial which is called Polar trial, published in JAMA in 2018, 3 years after the Eurothumb trial. It investigated early sustained prophylactic hypothermia on neurological outcomes. Multinational randomized trial, 511 patients divided into two groups. One received early hypothermia for up to 72 hours, or at least 72 hours, followed by slow rewarming, and others managed with normothermia, that was 37 degrees Celsius. The primary outcome was, as I said, GAUS score. They did not find any significant difference between the hypothermia group and normothermia group as far as GAUS score is concerned. GAUS score, so it showed actually the favorable neurological outcome was same, about 48.8% in hypothermia group, 49.1% in normothermia group. Actually, the score was little higher, okay, in normothermia group. So again, it showed no difference. Eurothumb trial showed harm. So this is why we should not use hypothermia for such patients. Now, what about the role of tranexamic acid, which is a medication that reduces the bleeding by preventing blood clots breakdown? So in this regard, the biggest trial is the CRASH-2 trial, which was performed in all kinds of traumatic patients. So it showed that if the CRASH-2 trial showed that if TXC is given within 3 hours of severe injury, it can reduce the deaths from bleeding by 1/3. It is quite significant. So by about 30%, it can reduce the bleeding. Questions remain about the effectiveness of tranexamic acid in TBI, and that is the reason CRASH-3 trial was done after CRASH-2. It was published in Lancet in 2019. It was a randomized trial in 175 hospitals, 29 countries. It is a very, very big trial. It included patients with TBI within 3 hours of injury and Glasgow Coma scale of 12 or less. So less than 12 GCS, all patients were randomized. Any intracranial bleeding in the CT scan. A total of 12,737 patients, about you can roughly say 13,000 patients were assigned to receive either tranexamic acid or placebo, and the primary outcome was head injury related death within 28 days. This was the primary outcome. So head injury related death within 28 days was actually lower. In case of tranexamic acid, it was about 18.5% compared to 19.8%. I think the risk was little lower with the TXA group. Trial noted a reduction in the risk for the mild to moderate head injury, but no clear evidence for the benefit in the severe head injury. This is very important finding. So it showed minor improvement if you take overall patients, but if you just do a subgroup analysis in patients with a mild to moderate head injury, okay, with GCS of 9 to 15, the effect is significant. Can you see? It is quite away from the midline of 1, okay. So it is quite away and it shows improvement. It favors the tranexamic acid. However, the effect size is less, but it shows the improvement in the primary outcome. Okay. However, in the severe cases, it is just adjacent to light. However, this is the larger effect size, I mean larger sample, but it did not show any significant difference. Okay. So in the severe cases of head injury, tranexamic acid does not help at all, only in the mild to moderate cases. This is very important finding from the Lancet CRASH-3 trial. Okay. Additionally, a smaller randomized double-blind trial was conducted in 20 trauma centers in USA and Canada. So this was a USA-Canada trial in about 1,000 patients with moderate to severe TBI. The primary outcome was favorable neurological function at 6 months assessed using GOST score. So they found no statistically significant difference between TXA, that is tranexamic acid group, versus placebo group, with all-cause 28-day mortality at 14% in tranexamic acid group and 17% in placebo group, which was also not significant. So there was no difference, okay, in the primary outcome or in the mortality. So you can see here favorable neurological outcome in the combined tranexamic acid group versus placebo at 6 months was not significant here. Okay, it was 65% versus 62%. Difference 3.75%, p-value 0.16, not significant. So this is another, important study showing no effect of tranexamic acid in the severe cases, but maybe in the mild to moderate. So still we are awaiting for one big study which can establish the efficacy of tranexamic acid in mild to moderate traumatic brain injury patients. What about steroid? I'm sure you are aware of that steroid is not useful at all, but which was the study which established the harm of steroid? So before 2004, corticosteroids were used for head injury rampantly. But after the landmark trial, which is known as MRC crash trial or just crash 1 trial, things change dramatically upside down. So this was a trial published in Lancet involving 10,000 adults with serious head injuries across 239 hospitals in 49 countries. Very big trial. Treating participants within 8 hours of injury, it showed that methylprednisolone, which was used in one group, okay, was not at all able to show favorable outcome. Rather, it increased the mortality. The death rate was 21% in the corticosteroid group compared to 18% in the placebo group, indicating higher risk of harm, okay, that is death. And follow-up at 6 months also revealed higher mortality and severe disability in the corticosteroid group. So this trial was the landmark trial, the MRC crash trial, which showed that steroids are harmful in traumatic brain injury patients and should not be used because it can increase the mortality in them about by 3% difference. Thank you so much. I appreciate your support for my channel and efforts to disseminate knowledge that may help you succeed in critical care medicine examinations. Please subscribe to my YouTube channel. Have a great day. We will meet again in my next video on the clinical trials. Thank you so much.